Um,
Perfect. Well, welcome everybody. Susie Stark hiding out with my video not on. I'm parenting today, so I'm not in the office. I'm off. But I had to tune in to join this discussion with Eric Lenz. I know that many of us in the research network have concerns about the mental health of our folks that are aging, particularly with long-term physical disabilities. And you've been asking, so we deliver. We have with you today Eric Lenz, who is the chair of the Department of Psychiatry, an amazing person for us to talk to because his roots really are in geropsychiatry and in rehabilitation. He is an amazing clinician and he's also an amazing scientist who's really helped us understand better how we can develop behavioral interventions to treat people who are going through rehabilitation issues and also to understand the interface of mental health and medications and behavioral interventions and how they can support people in their daily lives. So, a really impressive person that we are so grateful to have. And I think this is one of our biggest webinars ever, Eric. So I know that people are dying to hear what you have to say. So I will mute and I'm looking forward to hearing this discussion. Thanks for coming, Eric.
well, thank you, Susie, and I'm really happy to be here. I've been a longtime friend and admirer of Dr. Stark, so it was really hard to pass this up when she invited me to come speak. Well, welcome, everyone. Let me just quickly introduce myself. My name is Eric Lenz. I am a professor of psychiatry at WashU School of Medicine. I am a geriatric psychiatrist. Since 2022, I've been the head of the Department of Psychiatry at WashU. In spite of that, I do remain an educator, a clinician, and a researcher, all focused on geriatric mental health. And that will be the basis for a lot of what I say here today about depression in older adults. And I'll just add one more point to that before getting started, which is I do have some slides here. There were some points I wanted to make to kind of get us started, but I really see the main point of this as an interaction. I want to hear what you guys have to ask and what your pain points are for your patients and families. See if there's something I can help you with. So go ahead and get started. What you see here is something that I think everyone in this group knows. The population of age is aging. But I want you to look at the yellow and blue bars. Those are the numbers of people and projections of people of advanced age. These are people who are aging and still living in spite of medical conditions and disabilities that, if we're being frank, would have killed them or us decades ago. Now we're seeing people live longer and live longer again with disabilities, with many comorbidities. So how does that play out in terms of geriatric depression? I'm going to wheel us back to 1995. That was my intern year in psychiatry. So I was a trainee then. And this is what geriatric depression care looked like by and large back in 1995. I'm going to read this out to you as if you were me hearing a case 30 years ago. 65-year-old woman presenting for depression care. She's never had mental health care before, and she takes no psychiatric medicines. She takes 3 medications right now for arthritis, hypertension, and coronary artery disease. Sound familiar? No, it probably doesn't. Let's go now to the present. And this is what a typical case looks for me in geriatric depression care. 78-year-old woman presenting for depression care. She has heart failure, stage 3 renal disease, diabetes, hypertension. She's been hospitalized 5 times in the last year, the most recent for complications from uterine cancer surgery. She's had a stroke and she has cognitive and balance problems. She takes duloxetine plus bupropion. She previously took venlafaxine, escitalopram, and mirtazapine. Don't you like the long names we have for our antidepressants? She takes 25 other medications, six of which are active in the CNS or in the brain. She takes several supplements, including melatonin, and then she drinks daily and uses gummies at night to sleep. Maybe that sounds more familiar to our audience. It certainly does for me. What am I trying to exemplify here? Well, the first case is one of what we would call low complexity, low clinical complexity. Her depression could be managed in a routine primary care setting. The second case is one of high complexity. Treating her depression is outside the scope of most physicians. It's going to take an expert. It's going to take a lot of time and effort to help this person safely and effectively. And we know from those aging demographics I'm showing you here that we're going to see more and more people like the second case. Okay, so doing that care is the job of geriatricians and geriatric psychiatrists. But while the aging population is going up, the payment to these doctors, us doctors, is going down. What you see here is a huge and growing gap where Medicare payments actually have gone down in real dollars over the last generation. This only shows out to 2022, but there's been a further gap, a growing gap even since then. And then matching this drop in Medicare payments, unsurprisingly, is an equal drop in the percentage of psychiatrists accepting Medicare. So if you have patients saying, why can't I go see a psychiatrist? This is Exhibit A for that. As a result, geriatric depression care in the community, it gets an A, but not the kind of A you'd want. I'm talking about inaccurate assessment, low adequacy of treatment, and alarming rates of inappropriate medications. What do we do about that? Well, there are some tools we can do to overcome these low quality care issues. The first is something called measurement-based care. This is something that can be done in primary care or, in fact, any settings. A simple tool like what you see here, something called the PHQ-9, when given to a patient at each appointment, can track depressive symptoms over time, indicating what the severity of them is and whether they're improving with treatment. I continue to use this measure. It's actually a paper form that I hand out to patients at each appointment, costing nothing except their time. And I can tell you that it improves my care of patients, and there's a lot of evidence showing that it improves care and outcomes in other settings. Well, there's a lot of treatment choices for depression, a dizzying number of medication options, and what you see here is what's grown over time. So how do you choose the right medication option? I'll get to that in a minute. But one of the things that we increasingly need to push is a combination of medications with psychotherapy. And in fact, that's something in the specialty mental health sector we do all the time. Psychiatrists and advanced practice providers will provide psychotherapy alongside our medical management. But then for those who need more intensive psychotherapy, most likely we're going to refer to a therapist. And then doing all those things above that I described, it is complicated. It's certainly complicated for patients seen in primary care. However, there is a model of care that can help with that, and that's called collaborative care. It's an evidence-based care tool to implement some of the things I showed you. In collaborative care, you have these additional people and tools that you see here. Sorry, my slide advancer is not advancing. Let me there we go. What you see at the bottom are key components of collaborative care, where added to the primary care physician, you have a behavioral health care manager who uses a registry to track patients over time and gets the assistance of a psychiatric consultant. It's actually the behavioral care manager, also often a social worker or licensed counselor, who has the most interaction with the patient and works with a primary care doctor to bring high quality mental health care, medications, and psychotherapy into the primary care setting. And then when that's not enough, in the specialty mental health care, increasingly we have a service that we call interventional psychiatry, where we offer the services you see there. On the left, TMS or transcranial magnetic stimulation. In the middle, ketamine, either IV ketamine or intranasal S-ketamine, which is FDA approved for treatment-resistant depression. And then on the right, ECT or electroconvulsive therapy, a treatment that has improved over the last several generations to become safer and better tolerated and more effective. It wouldn't be a talk about geriatric depression in this day and age without talking about polypharmacy and deprescribing. I have to say, as a geriatric psychiatrist, I spend much more time reducing patients' drugs than adding new ones. And this is an extraordinarily complicated and time-consuming effort. Why? Patients are on a lot of different drugs. There's psychiatric drugs like antidepressants. There's other medications that enter the brain and therefore have either psychiatric or cognitive effects, like bladder medications, bowel or GI medications, and allergy medications. Then there's drug-drug interactions. The more a certain kind of drugs you take, the more likely they're going to have effects on the other drugs you take. Plus, increasingly, older adults are using alcohol, cannabis, supplements, etc. There's a lot of research that's been done to figure out the best way to treat depression in older adults. What I'm showing you here is a synthesis of that research, numerous clinical trials, a synthesis of that into what I call an evidence-based care algorithm for depression in older adults. Going from the top, medication-wise, an SSRI is often the best first choice. And if this is the patient's first medication trial, they actually have a very high chance of benefiting from that, greater than 50% chance of remitting. If that doesn't work, switch to another medication. That second trial still has a pretty darn good chance of remission of almost 50%. If that doesn't work, add a second medication, what we call treatment augmentation. And then if that doesn't work, further medication trials are unlikely to help, and the patient needs neuromodulation or ketamine. Adding to that information is a few things. One is these initial medication trials can be done in primary care using collaborative care and measurement-based care tools to improve those outcomes. Some of those bottom options there really need a patient in specialty care. They really need to see a psychiatrist for that. One other point I'll make is that psychotherapy fits anywhere in this algorithm, and many patients prefer psychotherapy to medication and may respond to that alone. But there's also some bad news here, which you can see in those declining percentages. That is, the more treatments that have failed, the less likely the next treatment is to work. So we need more research to figure out how to best treat patients with depression, especially when the initial treatments don't work. I'm going to finish here with talking about what we're doing and what we've been doing at WashU, and specifically at WashU Psychiatry. We have conducted and in fact led a number of trials to advance treatment. What you see on the top left there is an example of some of the high-profile patient-centered research that we've been doing. This was a study published in the New England Journal of Medicine 2 years ago, where we examined the different benefits and risks of various antidepressant augmentations or changes in older adults with depression that was treatment resistant. Importantly, we conducted this research with patients as partners, funded by the Patient-Centered Outcomes Research Institute. You can see, for example, a quote from an older adult with depression who said, "I want to know the positive and negative effects of antidepressants as I age," which was one of the things that helped us design that study. On the bottom right, you see some of the kind of innovative research that goes on here. Many of you know about the attempts to use psychedelics to help people with mental illness. We recently published a paper where we combined psychedelic use with advances in neuroimaging called functional mapping in attempts to try to get to precision medicine, meaning figure out why and how psychedelics work and use that information to figure out who would benefit most. Older adults, as Dr. Stark mentioned at the beginning of the hour, they're often seen in settings where mental health services just don't exist, like rehabilitative settings, but also like the perioperative setting, where anxiety or depression can both destabilize before and after a major surgery, and they can adversely affect outcomes like recovery, leading to further disability. So at WashU, we created what is still the only Center for Perioperative Mental Health. This is bringing together a huge multidisciplinary group of researchers, again, working with patients and family partners to develop compassionate patient-centered support for individuals battling mental illness, such as depression. What you see here is a model of that of the care that we've been designing in the Center for Perioperative Mental Health. When surgery is scheduled preoperatively, we reach out to begin interventions, including psychological and care management that is usually led by community social workers, and medication optimization, which is usually led by hospital pharmacists. That care continues in the hospital and then postoperatively as people go into recovery transitional phases such as nursing homes up until 90 days postoperatively. We've recently finished some studies in that area and we'll be publishing those findings and then ultimately trying to get these interventions out into real world care. You can't do this kind of innovative treatment and research without a workforce. And so WashU Psychiatry has been focusing on educating the workforce. We are the largest training program in the region. We currently have 54 residents, and I'm happy to say we just expanded to 16 residents per year. So that's 16 new psychiatrists, many of whom stay in the St. Louis area to provide care, as well as child and adolescent fellows. In fact, we just started a training program for psychiatric advanced practice providers as well, because we know that that's an essential part of the workforce to provide psychiatric care in the community. And then we're trying to make a difference for patients. That is, we're working towards a future where high quality mental health care is easy to access and is available to all. That's our mission. That's our North Star. We're certainly not there yet, but I can tell you that our clinical services have been growing and growing a lot. In just the past 3 years, we've grown our outpatient services by over 200%. We now have a large interventional service where people can get neuromodulation or ketamine for treatment-resistant depression. This very month, we're opening up a new outpatient psychiatry practice at Missouri Baptist Hospital. We have started collaborative care at several primary care practices, and we're going to be expanding from there. And next year, we're opening up a child psychiatry hospital in Webster Groves with the hopes of expanding adult and geriatric services after that. Unfortunately, the recent federal attacks on universities and threats of even further financial cuts have been, I have to admit, putting a damper on these efforts, but they have not stopped us. This is my last slide here. I just want to reiterate some of these take-home points. The fact is, depression care for older adults is getting more complicated. People are living longer with more disabilities, more comorbidities, more medications, more polypharmacy, more and of course more challenges in treatment. But simple principles can overcome many of those gaps in care. Things I showed you, like collaborative care, measurement-based care, and making sure to get a patient to see a specialist when care settings like primary care are not getting a patient better. And WashU is leading the way in research, education, and clinical care, both for the region and for patients everywhere. All right, I'm going to stop sharing my slides here and hope that people have questions for me or other things that I can uh, help you out with.
Thank you, Eric. That was really, really great overview. I think you are going to have lots of really, I can see who's on this meeting. You're going to have lots of really complicated questions, and I think that you can answer them. So I'm looking forward to this dialogue. Sure, Donna, do you want to run the question and answer for us?
Absolutely. So if anyone in attendance has a question or has something you want to discuss, you can unmute and say it out loud, or if you want to put it in the chat, we can read it there. So we'll start with that and see if anyone has anything in particular.
I have a question. Hi, Andre Denny, working at both the Memory Diagnostic Center as a social worker and the Alzheimer's Center. I wonder, Dr. Lenze, if you think, I know we try anytime we can ever get in with you or others in your practice to have some of our people with more advancing Alzheimer's or other dementias that have a lot of behavioral agitation, anxiety, depression symptoms. And I'm wondering if you think those are best managed when possible, when available by a geriatric psychiatrist versus by their neurologist or GPs.
Yeah, it's nice to see you, Andrea, and that's a great question. I would say there's a big gap between what's ideal and optimal and what is possible. Um, I would say that managing behavioral disturbances or in Alzheimer's disease can be incredibly challenging. Uh, Frankly, most of the best treatment is behavioral and environmental. However, it's extremely difficult to get care like that, as you well know, provided in these really kind of low-resourced settings where there's a lot of turnover of staff. In other words, you teach some staff at a nursing home or another setting how to do care for people with Alzheimer's disease, but then they quit their job within a few months, and then you have a whole new group of people to try to train. So I think that the current situation we have with staff turnover and low resources makes it pretty hard to do in behavioral environmental um, interventions. And so what does that leave then? It leaves medication interventions, which have not a lot of evidence that they work often and have a lot of safety issues and risks. Um, again, going back to the point that Medicare payments to physicians have been dropping greatly. I think you know as well as I do that that's really led to a dearth of geriatric specialists. Uh, um, so I think finding a geriatric specialist, say to consult at a nursing home, or to be easily available to provide care is increasingly hard. That you know I that's kind of the bad news. That's the gap that I think that you're seeing every day in Alzheimer's care, the behavioral care of Alzheimer's. You know,
Absolutely. Thank you.
thankfully, due to the research that you guys are conducting, I think we'll probably see less advanced Alzheimer's disease in the future. But, we thinking about the current generation of patients and families dealing with Alzheimer's disease and the behavioral disturbances from it, that it's a really challenging prospect.
Thank you.
So, Eric, I have a question about what do we do when we are providers and we're aware that our the folks that we're working with in the community have tried to work with their primary care physician and are not getting, I guess, a therapeutic response to whatever has been tried. And we see, let's say we used a screening tool and we see depression is an issue and we're not quite sure where to go. Where do you recommend those of us hanging out in the community that don't have access to a system like WashU, how do we get into that system, or how do we get people to the care that they need? What do you think would be best practice?
Well, yeah, it usually starts with the primary care doctor. I mean, that's who's usually referring people to me or other psychiatrists. And the fact is that for many of these older adults with depression, if they're battling disabilities along with depression, then we're probably talking about people who have the need of an advocate for them. I think in reality, for geriatric depression care, a family member is acting as essentially an ad hoc care manager for that patient, or case manager, I should say, for that patient. So, and if there's not family available to do that, many of them probably need a formal case manager, someone who understands and knows the system, and can navigate them through it and advocate for them.
Thank you.
There any other questions in the group? I can go on, and we have some prepared questions. So a number of our attendees are in the community. We have city, rural, and there are community agencies that serve people aging with long-term physical disabilities. And one of our questions was, what are some of the most common factors that contribute to the development of depression in older adults, specifically those who have long-term physical disabilities, and how are those usually addressed in treatment?
That's a great question. I think you could kind of imagine sort of two types of depression broadly in older adults. One looks more like depression in younger adults. It tends to be more early onset in age, and people continue to have battles with depression as they age into older adults. And these for those individuals, the treatment for their depression tends to be the same as it was when they were younger adults. But there's another kind of depression that tends to present or worsen later in life. It tends to be closely tied to disability itself. That is, older adults with high levels of disabilities have much, much higher rates of depression than healthy older adults do. And in that case, it tends to come with a lot of, let's call it comorbid impairments, like particularly cognitive impairment. It's in that setting, it tends to be harder to treat with medications as well as with psychotherapy. So those are individuals that are going to more often require specialty care. I think the other thing to say is that probably many of you may be in what I would call transitional care settings. That is, that you're seeing older adults in settings where they're only there for maybe a few days or weeks, and then they go into another setting after that. I think it's as people go through those transitional care settings that we see high rates of issues like medication reconciliation issues, a medicine someone was on before, all of a sudden they're not on it anymore as they go through these care settings, or some of these kind of polypharmacy issues that occur as medications get added on as people go through these settings. I think it's here where, like a pharmacist, like for example, a hospital pharmacist that we rely on in the perioperative setting, can be very helpful in managing these medication reconciliation and polypharmacy issues.
Do you find that like chronic pain and fatigue can contribute to depressive symptoms?
Yeah, and vice versa as well. So it's a um, you could think of those as bidirectional. You can also think of also kind of a diagnostic dilemma where an older adult's presenting with fatigue and you're not sure if it's related to depression or if it's something else causing the fatigue and just sort of looks like depression. I often see, for example, older adults getting prescribed antidepressants when they don't really have a clinical depression at all, but they have something else like pain or fatigue, or even like cognitive problems or apathy from dementia. Again, that what I described as measurement-based care can be really helpful there. An instrument like the PHQ-9 can help a provider in a real-world setting make a more accurate diagnosis, differentiating clinical depression from some of these other syndromes. But as you said, often people have both.
Do you think pain should be treated in people with chronic pain? And if so, how?
I'm not really a chronic pain specialist, and I'm certainly not an acute pain specialist. So I don't have really expert answers for that, but I think there are many ways to treat chronic pain. And yeah, certainly that should be addressed in individuals.
How do we get medical professionals, physicians, etc., to recognize that chronic pain is still pain? I know we fight that a lot in the rural areas.
I Yeah, I guess I'd want to know more specifically what you're battling in that issue. Certainly, by definition, chronic pain would be pain.
Okay. We've got some questions in the chat. How are the advances in medications to effectively treat or even cure Alzheimer's dementia diseases coming along?
Yeah, could probably ask Andrea Denny to describe this better than I can, but the advances are really, really amazing for here I'm talking about people who are in the very, very initial stages of Alzheimer's disease. I can just describe it how it's changed my practice and how I think of this. Uh, just a couple of years ago, if a patient came to me who with cognitive complaints, my thinking would be, well, there's no really good way to accurately diagnose easily and accurately diagnose whether they have Alzheimer's disease. And it really doesn't matter anyway, because there's not anything I'm going to do to change the course of it. Everything I just said there has been totally turned on its head. Now, if a patient comes to me with those same complaints, I say, there is a simple and highly accurate blood test, not a brain scan, not a spinal tap, a blood test that can tell us whether you have Alzheimer's disease or not. And if you do, there are infusions that can bend the curve, slow down the course, in the ideal case, maybe even stop it in its tracks. Now, of course, there's a lot of caveats to that. These treatments are expensive, they're cumbersome, there are safety issues to it, and they're no panacea. But, you know, to some extent, I feel like a decisive battle in the war on Alzheimer's has been won. And over the next few decades, what I think we'll see is increasing improvements in that care, such that the next generation of older adults will get treatments that really greatly bend the curve, and like I said, slow down or ideally even prevent them from getting the kind of impairments that we see in dementia.
Okay. All right, we've got another question in the chat. How available is genetic pharmacogenic testing for the geriatric population in determining which SSRI or other medication for mental health is the best fit for the individual?
It is available. I don't know how often people in like primary care settings use it, but there are, I guess the one I'm most familiar with is the GeneSight test. The most valuable part of that genetic testing is usually to tell you whether a certain individual has a genetic predisposition to being what is called a very slow metabolizer. In other words, if you give them a dose of medication that's average for most people, it's going to build up in their system, and it's going to be a high dose for them. Then there's an approximately equal number of people who are called ultra rapid metabolizers, and their livers just metabolize those medications really quickly. So an average dose for most people is going to be a low dose for them. I have to say I don't order those tests very often because usually what I'm doing is choosing medications that have simpler metabolism that don't rely uh, aren't affected by those genetics in the first place. So in a large way, you can kind of avoid the need for genetic testing just by which medications you choose. But that said, for certain medications, if you're finding that a person either has side effects at a low to average dose, or they don't seem to respond to medications at a typical dose, these can be helpful in trying to understand that.
And there was a question about the name of the blood test you had mentioned, and then Andrea wrote, is it Precivity AD? Is that
Activity 82, and of note, well, the tests, as Dr. Lenze said, of course, are getting quite accurate. They can't just be given yet in the general public. They would be given by a specialist if someone had memory concerns already and they're not yet covered by Medic. We're hoping the approval is coming soon for it to be covered by Medicare, et cetera. So they're an out-of-pocket charge, but they are used. And of course, there's things like the scans and the spinal taps that sometimes people are afraid of or don't like because they're more intrusive or less normally, less familiar, but sometimes those are covered by insurance. But as Dr. Lenze says, it's a different world where if you're with a specialist, they can determine, not like on autopsy, like we used to think, but in life, if we think you have the changes in the proteins that signify Alzheimer's, and then potentially, depending on your vascular risk and how early you are, could be receive Leqembi or Consula, one of the two approved infusion therapies. Anyway, sorry, more than you wanted to know.
Thank you.
Yeah, I think the bottom line is that right now it's a little bit hard to get people to get that blood test, and there's only certain places. In fact, I think in the Andrea would know better, but I think in the St. Louis area, maybe the WashU Neurology might be the only service that provides those infusions and all the care that has to be done. Again, often for the reasons I showed you, at a financial loss to the physician to provide that care, but but I think that's going to that's going to be growing over the next few years. That'll be a big change. But again, that's a change for people who don't yet have, full-on Alzheimer's disease with dementia. This will be important for people at the very earliest stages of cognitive problems when you're first starting to notice any cognitive problems. Um, as far as people hoping to cure existing Alzheimer's dementia, I don't, unfortunately, that's still speculative. It's in the area of more science fiction than actual science. But I think preventing the decline in the first place is a pretty darn big step in that.
It's another question that came up in the chat. What is the future of home-based elder care, and do you see any new innovative ways to support aging persons before 24/7 nursing home care?
Well, that's a really good question. I wish my colleague Angela Martin Davis, who's the head of BJC Home Care, would be able to answer that. As far as new and innovative ways to support aging people, you know, uh, I guess a lot of people feel like, robots and chatbots are coming down the way, or other technology. I have to admit I'm pretty skeptical of that, because technology always seems to break down or mess up when you
Need it the most.
least expect it. So I think innovative ways outside of that. Um, what 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 we're doing again in the Center for Perioperative Mental Health is trying to use existing providers, community social workers, hospital pharmacists, and get them into these other settings, get them working in these settings in ways that can help people. So I think people power is still going to be important. The robots aren't going to take over all our jobs.
All right. Another question, are there certain impairments, whether a mobility impairment or a sensory impairment, that have a higher correlation with depression in older adults that you've seen?
Generally, it's a great question. Generally, the more that impairments either reflect underlying brain disease, or the more that they cause, measurable disability, like dependence on others, the more related to depression, and let's call it depression inducing, they will be. In fact, you can even follow this in, for example, like a person who's had a hip fracture, that as at the beginning, as they are the most disabled from it, they'll have the highest rates of depression, and then as they hopefully recover well from the hip fracture, their symptoms of depression improve. Um, you can also see some of the highest rates of depression after something that's not only disabling but affects the brain, like a stroke. Post-stroke depression, for example, is a pretty common problem.
I'm going to open it up to the group. Does anybody have any other questions? Be brave, speak up. I'll keep going with our prepared questions then. In your experience, as people age and their roles and relationships start changing, retirement, loss of independence, all that, do you notice that influences mental health in our older adults?
Well, yeah.
Yeah, it really, whether a change in someone's social role either increases, or for that matter decreases depression, uh, probably really depends on, how much purpose and social connection someone had in that role versus how stressful it was. I've seen it both ways. I've seen people develop depression after they retired, probably because of, isolation and a loss of sense of purpose. And then I've seen people who were depressed or maybe very anxious as well have that resolve after they retired. just because their job was so stressful in the first place that it was just a constant stressor for them. So I seen it go both ways, but I do think that what you're touching on, both social connection versus isolation and the sense of a purpose versus lack of that are two huge psychosocial factors that induce depression and, of course, are affected by depression. Again, this is where psychosocial approaches like therapy and environmental supports and changes really, really are a huge part of the management of depression.
And can you explain the role of stigma and societal perceptions in mental health of older adults, specifically with disabilities?
Yeah, I mean, I would say one piece of really good news about mental illness is that I would say across the board, across the lifespan, stigma has been declining. I mean, I think looking here, there are many of us who are on this who are old enough to remember that it was routine to blame the patient and their parents, usually the mother, for a mental illness as a moral failing, of that patient and the family. Um, and I'm not saying that that's gone away completely, but I think that's much, much better. And I would say it's largely due to individuals with mental illness themselves and their families speaking out, really advocating for themselves over the last several decades. So I think there's a lot of good news there, again, across the lifespan, including older adults. I do. I do find that older adults are more willing to talk about depression and other mental illness than they were a generation ago. Are is there still stigma? Yes. Are societal perceptions something still needing change? Yes. Are there still influencers out there in social media who have all sorts of scorn and guilt-inducing statements to say about people with mental illness? Certainly, yes, but there's a lot of positive change in that direction.
And another question is, how does a family member advocate or support aging parents or an older adult who may not be aware they may be struggling with mental health?
Gosh, I hear this all the time, all the time. It really is like kind of taking the bull by the horns, uh, which of course is a very evocative metaphor because it seems like you're going to get gored if you do that. But so if I think that's easiest perhaps with a spouse, because I think people are frankly kind of used to their spouses being involved in their affairs. Otherwise, they wouldn't have gotten married in the first place. But I think the big challenge is for adult children or other people. You're put in an unnatural position by reaching out and becoming essentially someone who's telling your parent what to do and advocating for them. But that's exactly the position that adult children of aging parents often have to do. In fact, they are going to, if that older adult has some degree of disability, if their depression is impairing them, certainly if they have even a small amount of cognitive impairment, they are going to need an advocate. They are going to need, usually a family member. In our society, it's almost always a family member to be an ad hoc case manager for them. Get them to appointments, make sure the doctor or other people know what's going on, get them to take their medications correctly, ask tough questions of every provider they see in every setting they see. That's it. It's a job and it's tough, and it's often a thankless one as well.
Yeah, I've heard the phrase sandwich generation a lot, where you have family members that are raising their own families, but then are also caring for their aging parents. And definitely is a lot of stress for sure. So,
Yeah.
all right, couple of things. Well, another question, how do you approach and reach the Black geriatric community? In my experience, older adults in this community are often much more hesitant to seek mental health care that includes medication due to how they've been treated in the past.
Yeah, that's a really great, it's a great point, and it's a great question as well. I think I think we have to be doing a better job of that. I would say on the one hand, there have been studies of this, and they have shown more or less, let's say, medical trust from Black individuals than white individuals. On the other hand, if you look at once someone gets, the possibility of a referral treatment, the outcomes actually seem the same. We actually did a study on this years ago, and we found that the outcomes of treatment of geriatric depression were equally good with Black patients as white patients. And I have to say, I've often heard from Black patients themselves that they actually they had to overcome, people not referring them for care. So they had to they had to push for getting care themselves. So I guess I would say don't assume that because there's a generally higher level of distrust that your Black patient does not want care for their mental illness or their family's mental illness.
There was a comment that came up. It says it can be similar in the Hispanic community as well. Do you see that in your practice?
Yeah, I think it very similar, and I think with the additional barrier of not just a cultural barrier but a language barrier for older Hispanics for whom English might not be their first language, or they may not even be adequately fluent in it let's say advocate for themselves in a medical setting. And let's be honest, I think in the last 3 months that's gotten far, far worse. I can tell you that in medical settings, including psychiatric settings, in the past 3 months, since about January 20th, we've seen a dramatic reduction in Hispanic patients and other ethnic groups, immigrant groups seeking care. That's across all care settings. I don't have a good answer to that. At least I don't have a medical answer to that.
Another question came through. Can you explain how family is involved in psychotherapy for geriatric patients versus children? For example, do families participate in sessions with the psychedelic treatments?
I don't know, not with psychedelic treatments, but I would say that that psychedelic treatments, that's still research there, that there's not enough evidence, in my opinion at least, to be recommending psychedelic treatments to people as actual care, and certainly not enough evidence in older adults, although it's an exciting area that maybe 10 years from now we'll have some answers about. I really like the question though about like family involvement in a patient's care, including in psychotherapy. Let me just make two points about that. Okay, one is geriatric care can be, should be, usually must be family focused, right? It's patient centered but family focused. I can tell you that anytime I go to a waiting room to see a patient, if there's a family there, I say, hey, do you want them to come? Maybe they should come as well. Because in a sense, I deputize the family member or members as part of their care. The second thing is, if a patient has cognitive impairment, even what we call quote unquote mild cognitive impairment, which in my mind is anything but mild, but that's our term. Psychotherapy, unless it involves a family member, is probably not going to work, right? Because psychotherapy is learning based. So unless there's a family member there participating in that and making sure that the patient can keep transferring what's being done in a psychotherapy session to the home and other settings, in many cases, I don't think it's going to help. So those are just two instances where a family member's involvement is essential, I think.
Do you have any examples in your practice where mental health is such a complicated thing, right? And sometimes people struggle through treatments, and you try things and they don't work, and side effects and all this stuff. Do you have any, I mean, I hate to use the word success stories, but do you have any examples of patients who've come into your office and have received positive impact from the various treatments that they've needed?
I just saw a patient yesterday who looked great. He has had one of the most treatment-resistant cases of depression I've ever seen. It didn't respond to ECT. It didn't respond to transcranial magnetic stimulation. It didn't even respond to vagal nerve stimulation, where that neurosurgical procedure where they put a vagal nerve stimulator in you. Didn't seem to respond to any medication. And I have to say, we really had to fight for this person to get S-ketamine, and we had to figure out what other medications for him to stop taking to get it to work. But we finally figured it out, and he is feeling better. I can tell you about another patient I saw. I'm still seeing her. She developed a depression late in life that was so severe she became catatonic. So, and she was actually referred to me by the Memory Diagnostic Center because people thought she had a rapid onset dementia, a severe dementia. We gave her ECT followed by some medication optimization, and she is living her life today. You would have not ever known she had any mental illness at all. You could see her in a store or something like that and say, this person, you wouldn't have guessed she ever had any mental illness in the first place. I will say there are great outcomes people can get from good treatment of mental illness. If you don't have dementia, like I said, we can't cure dementia except in a few very, very rare cases, right? But most of these mental illnesses are treatable. Depression, anxiety disorders, which are the most, and substance use disorders are very treatable. But I alluded to some of the systems issues, low payments, government and other policies that more or less impede access to care. And of course, often stigma and the patient's own lack of insight or lack of motivation coming from the illness itself can impede treatment. But if you get good treatment and you stick with it, you're almost assuredly going to get better. That's the good news with depression across the lifespan.
Eric, thank you so much for your insights and ideas and the hope that you give us all. We all are in various places trying to make sure that the folks that we serve get the best care that they can. And I think thanks for the insights, the updates, what's coming down the pike. It really helps us communicate to those we work with how to connect with folks like you to make sure they have optimal outcomes. I think please join me, everyone, in thanking Eric. Give him the big thumbs up on the emojis. He's agreed to make this presentation available, so it'll be on our Aging and Disability Rehab Network website, so you can access it when you need it. Thank you so much for joining us today.
Yeah,
really great.
If you would like I know we have a lot of new faces here and a lot of new attendees. If you aren't on our mailing list but would like the link to this webinar, if you could just put your email in the chat, we can send that to you also. So thank you so much for being here. Thank you, Dr. Lenz, for your work and your commitment and your time. And we just hope you all have a wonderful Friday and a good weekend.
Stay dry, everyone.
Thank you.
Thanks. Bye-bye, guys.